Namaskar, dosto. Good evening and welcome to yet another session on fertility, Dost, with very senior doctor. And we can say that we just add on the things, we just add on the topics which you suggest. And recently, we have many queries related to this particular topic, repeated miscarriages, or we can say that multiple miscarriages. So every time miscarriage is a sad thing, and when you won't be able to find out the exact reason behind that miscarriage, is again the sad thing. And when people says or someone suggests you that okay, if you are having repeated miscarriages, why don't you try IVF? Why don't you go ahead with some other advanced procedure? And then it's just a thought. Why IVF? Is IVF the only solution? Because I am conceiving, but my issue is that the conception is not going till end. So, can IVF make this conception healthy? Can this IVF can help me to complete my pregnancy journey, and can through IVF I can give the live birth? So these whole lot of questions, these whole lot issues just crop up in our mind, and at times we seems confused what to do and how to proceed, and again, which doctor should we visit. These pointers, these questions are really important when you are dealing with certain issues. So, today we decided to take up this session related to this topic only, and the topic is multiple miscarriages, and is IVF is the only solution. And to talk about on this topic, we have very senior doctor with us. She has more than 20 years of experience. And for arranging this wonderful session, informative session, the session on demand, I can say, we would love to thank UNS. So, viewers, let's begin the session with a very senior doctor, and please start pouring your queries related to miscarriages, related to IVF, or you can just post your queries on any journal thing. So, I'm adding Dr. Dakshyani to the main screen, and let's start with the session. Namaskar, doctor, and welcome to Fertility Dose. So, viewers,
Namaste.
today we have very senior doctor with us, Dr. Dakshyani from Apollo Fertility Center, Chennai. She has more than 20 years of experience, and she has we can say that make people smile, make couples smile when they visit her for the treatment. We can say that the diagnostic part, the suggestions, and the treatment, she has full authoritative control over those things. So, if you are dealing with such issues, if you think that you have any doubt related to these topics in your mind, then please post your queries. We all know that miscarriages are not good, they are not healthy, and this condition usually indicates that there's something that we really need to work on. Basically, we need to diagnose, we need to treat the thing, and for this whole topic, or for the solution of this thing, we have Dr. Dakshyani. So over to you, ma'am. Topic is multiple miscarriages. So first question, that why multiple miscarriages are happening to certain lady, what could be the reasons for this?
Yeah. Good evening, Purnima, and good evening to all. It is as Purnima just spoke about it. Um, and when it comes to a family, they are so thrilled to have a baby. So when they get a news, a bad news, like things have not gone forward properly after the conception had occurred, they are so finding it very difficult to accept it, or sometimes they're sort of they're very sad. The not only the couple, I see in an Indian culture family, like we see the whole family members are disappointed by the whole thing. When coming to miscarriages is a very common issue. Like in Indian women, our papers or our literature says it's around 10%. So that means to say 10 out of all 100 women who are getting pregnant are having some sort of miscarriages, unable to even catch up till 12 weeks of pregnancy. But the studies taken from various centers show that it could be even more than that. So it could be as high as 25 to 30. So the range could be like from 10 to 25% is the actual rate of miscarriages in our society. So there are various reasons for it. Like miscarriages, as Purnima was just informing, conception occurs, but there is the 40 weeks which we are looking forward to have a healthy bonny baby. There is some abnormality which is happening or some issue which is happening. Could be with the uterus, could be with the mother's health, or could be with the conceptus, that is the embryo, which is the one which has to grow into a good baby, or could be because of the abnormality which has already affected the baby. Maybe because of the chromosomal abnormalities, or maybe because of the mother's health, as in diabetes. In diabetes, miscarriage can occur anytime, like right from a small blighted ovum which goes into a blighted ovum, or it could be something like you have a third month, fourth month miscarriage also in a pregnant woman during diabetes, if diabetes is not taken care of. So recurrent miscarriages is what we call when a person miscarries more than 2 times. Okay, like if there is more than 2 times miscarriages and no live children in between, we call this as recurrent miscarriage. And again, as I told you, we have to go through the complete set of investigations to find out what could be the reason for this sort of a miscarriage.
Right. So, doctor, mostly people says that age could be the reason, stress could be the reason, bad gamete quality could be the reason. So, I would really love to have to discuss these topics one by one. So, first,
Okay.
we'll discuss that could age be the reason for this multiple
Exactly.
miscarriages.
Exactly. If you are looking at the reasons or the causes of miscarriage, we could actually broadly bring it into two things: the maternal causes and the embryo causes, embryo being the reason for it. So, when you are talking about the maternal causes, that is the mother being the cause for miscarriages, it could be, as you said, improper diet. Okay,
Hmm.
and her stress factors which can cause abnormal chemical mediators in her body, which can be one of the reasons for miscarriage. Because when a person is diabetic, if you have stress, the diabetes does not come into control at all. Similarly, even hypertension, if the person is in a stressful condition, her BP tends to go higher. So these things can actually cause problem onto the medical health of the mother. Then other reasons like the uterine anomalies, like if a person or if a woman has an abnormal uterus, like the normal uterus structure is like a pear shape with a nice triangular cavity inside. But if there is anything abnormal about the uterine cavity as such, in that you have like bicornuate uterus or a septum in the uterine cavity, all these things, or a very thin uterus, I mean, a very thin
Right.
hypoplastic uterus. So those uterus, or sometimes unicornuate uterus, there is uterus which is only towards one side. So all these things can be structural deformities where miscarriages can occur. And apart from that, you have the maternal diseases. Like, for example, hypothyroid also can cause miscarriage. Like, thyroid diseases can cause miscarriages, early miscarriages. And you have a set of viral infections, which the mother can have those infections, but she will not have a very big disease because of it. But if by that time she's conceived, she will usually lose those pregnancy. In fact, that
Oh.
I usually call it as a blessing in disguise, because if such babies continue to grow, they might show up with some anomalies as they grow up, which is usually picked up somewhere around the fifth month in the scan. And then at that time, we would be recommending them to go ahead for a termination of the pregnancy. Like, for
Hmm.
example, if you see toxoplasmosis, sometimes rubella, and the cytomegalovirus, all these conditions, the babies are affected so badly that their baby's head can be smaller than normal or larger than normal. So these things will be detected on scan on a later date, but most of them, they will usually miscarry around the 10th week also. Okay, so these are the maternal reasons where miscarriage can occur because of thing. And now we actually look at immunological factors also. Immunological factors, I mean to say, something like an anti-nuclear antibody. Like a woman gets pregnant, but then her own antibodies don't allow her to continue her pregnancy. So that
Right.
is one thing. We see the similar reaction problem in systemic lupus erythematosus. So this is also related to our immunity issues actually. And as in anti-phospholipid antibodies, where there is a problem with the blood supply to the growing fetus. So there will be some microthrombosis, that is small blood clots occurring, and this will stop the blood flow going to the fetus. So this also could be the reasons for early miscarriages. Other than that, the genetic reasons, like we have to look out at both the parental karyotyping also to see if there is any chromosomal abnormalities. So these histories we tend to take from the family also to know if there was previous similar miscarriages in any of their family, or if there was any abnormal babies, like say a Down syndrome,
Right.
or if there was a muscular dystrophy baby, or any
Hmm.
of those abnormalities in the families also, we try to take a history from them to find out if there is anything. In all these places, if you see, age is a big factor. Okay, so in pregnancy, the best age for a healthy pregnancy for any woman would be, say, from an age of 23 years within an age of 28 years. So that would be the best time, I would say. But then these days, women tend to do their post graduation, they go into jobs, and if you see the urban population, I'm seeing them, like we see many of our women who walk into our fertility center, like they are 30, 32, so they're just married. So it was
Hmm.
not a problem that they're trying to get a baby a little late, but it was their social aspects which they had come through. Probably the education, probably find a job, probably settle down, then get married, all those things, or a bit of late marriage also. So in these persons who come a little late, we do see them having issues, like issues like their AMH, that is anti-Mullerian hormone, which is actually telling us about the ovarian reserve, is already very low at around 30, 32 years for many women. So we'll be sort of taking them on a fast track to try and get that one baby for them. So when you see that there is a person who has a lower ovarian reserve, there is usually some problems like poor egg quality also. So a
Right.
poor egg quality can actually cause a poor embryo, and the poor embryo can actually have a tendency to have a miscarriage also. So when it comes to, be it a normal conception, be it an IUI conception or an IVF conception also, we have come across many miscarriages also. Okay.
Right.
So there is, like, even in IVF, we see like we have to do something above that to find out that we are trying to avoid those miscarriages also by trying and studying the embryos.
Right. We have seen that there are many, there could be many reasons, and the best thing is we really need to diagnose them first so that we can treat them effectively, as doctor just mentioned. So, ma'am, we'll here take one query uh, from the viewer. Hi, doctor. I'm 40 years old. I had two miscarriage, two ectopic, and two IVF failure. What to do? Please help me. All tests have gone like have done like genetic, apply, etc. All are okay. My one tube has been removed due to ectopic.
Okay. Parul at 40 years and two miscarriage, two ectopic means that means she had four pregnancies.
Pregnancies,
So
right?
yeah, it was not a problem for her to get pregnant. Maybe her age factor is a very important thing. We have to look out because her quality of embryo could be poor at this age because of the poor quality oocyte also. This is just a probability.
Hmm.
I would advise in this case to her to take an AMH test, the latest. Has she got a AMH report? Is she on a chat now, or is it only a
Yes.
question?
So, actually, this message is from YouTube. So, your live
Okay.
is the live is on YouTube also. So, we are like
Okay.
our viewers can see this particular live on three social medias: Facebook page,
Okay.
Facebook group, and YouTube. So, please, if you are in the session, please do post another. Like part of your question that doctor will just mention,
Yeah.
and then we
I
can.
want to know like if she has done the latest AMH because at 40 there is probability that her AMH would come down. So in that case, it is better that she has to plan for an IVF, and even if there are very few embryos, she has to have a pre-implantation genetic testing of the embryos before we transfer the embryos back.
Right. So she's saying yes, she's online. So please, ma'am, could you please repeat the question? What all details you really want
Yeah,
from her?
no, I want her to know. I mean, I want her to tell us if she has done a latest AMH test, blood AMH.
Okay, so please, yes, the AMH is 0.98.
Okay. If it is 0.98, I would advise Parul that she goes in for an IVF program again. And how many ever embryos she get, those embryos have to be subjected for a PGTA. Okay. And that is to make sure that we are seeing the good embryos and then transfer.
Okay, so when she had first IVF, she
Yeah,
was.
she was only 33 years at that time. Now it's 7 years gone. So she should not waste any more time. She could actually go in for another IVF cycle, but plan to do a PGTA, that is the pre-implantation genetic testing of her embryos. And when we find that the embryos are good, any one or two embryo is good, she can go for a transfer.
Right. So if Parul, you still have some few embryos in frozen state, then you can ask your doctor to do PGT. Okay, she is saying that donor bhi fail ho gaya. The donor cycle also failed.
Oh, really? Okay.
Mhm.
Out of the two cycles, she had one of self cycle and donor before. Okay, okay,
Mhm.
okay. Hmm. I would actually ask her to be a little more bold. No problems because look, hmm, 6 to 7 weeks
Seven
में
weeks.
miscarriage हो जाता था. Yeah. So that means to say that probably we are looking at what about her husband's sperm's quality is one thing we should really look at now, because if he has good quality sperms, that's fine. But if there is anything like a teratospermia or abnormality in the sperms, also sometimes abnormal embryos can be produced. If his some semen analysis was very normal, then let Parul do one more self cycle can be done. Actually, at 0.98, I would actually recommend her to go for a self cycle once again and send the embryos for PGTA. If PGTA embryos come out as abnormal, then accept that things are bad because of the age, and then go for a next donor cycle. Okay, her endometrium, is it? What is that? 45 mm?
I think maybe she's discussing about male parameter.
How millions?
45
It's 45 millions. Okay, could be. Yeah, millions. Yeah, that means to say the count is good.
count is good, right?
Count is good. Count is good. So she can definitely, because in IVF, if there is 45 million, what we require at this age, if she will be producing about 6 to 8 eggs, that's actually good. So we need that many sperms only. So I don't think I mean, she can go ahead for one more IVF cycle, but please recommend that. I would recommend that she has to go for a PGTA of the embryos.
Right. And if you really want online consultation with ma'am, please let us know. We'll arrange for that. And don't worry, as doctor said, that yes, you can move ahead with one more cycle. Just do the PGTA so that we can really know what is actually happening with your embryos. We can
And
understand
one more
the.
recommendation is probably if she's not done a hysteroscopy, because she mentioned to us about one uh, miscarriage also. So better before transfer, she will just look at the endometrium also.
Right. So she don't have any preserved egg, so that she need to go ahead with a
Fresh
fresh
cycle,
cycle.
fresh cycle. Yeah.
Right. So we would advise that please don't wait. Age is 40. We all know that. So waiting period is not there for you. Please, like it's don't mind, but it's the actual thing.
Yeah, if 0.98 is the latest AMH for her, done very recently, then she can try her own eggs again. If AMH is done earlier, let her repeat one AMH now before she really decides upon self cycle or go ahead with a donor cycle.
Lunar cycle, right. So, Dr. Dakshani, here I just want to know more about Escherman disease. Usually, we have queries related to this. So, could
Okay.
this be the reason for miscarriage also?
No, not the miscarriage. Actually, with a person, Asherman syndrome is a condition where actually the uterine cavity, where the endometrium layer is supposed to be a very spongy layer and free, like it should be like a cavity. In Asherman syndrome, there will be lots of fibrous adhesions inside the cavity. Okay,
Hmm.
so the endometrium would not be its normal self at all. Some people do have monthly bleeding even in spite of Asherman syndrome, but then their cavity is very abnormal. So this is usually diagnosed by looking at an abnormal looking or not an endometrium on scan not responding to the day of cycle. So it will always look the same echogenic endometrium, or it might always look like an echogenic endometrium without a proper trilaminar line. Like a three-lined endometrium won't be seen over there. That is one thing. And when you have something like that on scan, repeated transvaginal scans, when we keep watching a woman when she comes for her scans, if we see that the endometrium is not looking healthy or not growing along with the menstrual cycle, then in
Hmm.
that case, it would be recommended that we do a hysteroscopy. And hysteroscopy clinches the diagnosis of Asherman syndrome. So in hysteroscopy, you actually, as you enter the cavity, the cervical canal and into the cavity, you notice lots of fibrous bands crisscrossing the cavity
Mm-hmm.
and not allowing us to actually visualize the cavity full on a whole. Or sometimes we can't even make out the ostium on both the sides. The right and left ostium is not clearly seen at all. So in such cases, commonly we put in a copper T or an intrauterine device for some time, take a small biopsy bit, because look, in our country we know tuberculosis is still a disease. So
Right.
women, we can expect someone who's gone in for an Asherman's having something related to tuberculosis infection also. So we take a biopsy of the tissue over there and then try to put in a intrauterine device so that there wouldn't be much more adhesions over there, and then treat them accordingly. In Asherman syndrome, putting an embryo inside that place itself is like wasting an embryo.
Mm-hmm.
Okay, that
Okay.
is when related to IVF. We never put in an embryo if we are suspecting Asherman syndrome at all. But in a natural cycle, a woman would not know.
Hmm.
Usually, the embryo formation and embryo deposition into the cavity would not occur in such patients. So they will keep trying pregnancy, but a woman would not get pregnant with an Asherman syndrome.
Okay. And
So
if
not like, we don't think about abortions in these cases or miscarriages in these cases because they don't even, conceive.
and what about if the lady just move ahead with hysteroscopy and then try for natural conception?
Yeah. As I told you, we take a biopsy, we trying to treat them with very good high antibiotics for some time and put in a intrauterine device, say for about 3 cycles or so. And if there was a need to treat with anti-tuberculous drugs, say our endometrial sample which we had sent showed us that there was granulomatous cells inside the specimen we had sent, that would actually indicate that there is some tuberculosis infection also. So in that case, we would actually minimum treat them for about 6 months and then
Hmm.
advise them to go ahead with natural pregnancy. We remove the intrauterine device and they can definitely try for a natural pregnancy.
So, doctor, it's just that a recurring thing, this Asherman's syndrome, like.
Yeah, Asherman syndrome can recur. Yeah, it depends on how much of endometrial damage has been done. Sometimes this damage can be iatrogenic also, like it can be because of a miscarriage, and after miscarriage, remnant tissues was inside, and during curating that the tissues, both the approximating layers tend to get adherent to each other. So it could be like some bad obstetric history previously, some miscarriages also can cause Asherman syndrome. They can be one of the reasons why an Asherman
Mhm.
syndrome happened.
Right. So, could we relate, could we correlate this with overgrowth of fibroids also?
No, no,
No.
Asherman syndrome does not have any reasoning that there should be fibroids.
Mm-hmm.
Sometimes Asherman syndrome, I have seen it to like a person with Asherman syndrome might even show features like adenomyosis, that is
Okay. Bulky uterus.
endometrial tissue embedded into the myometrial tissue, and
Hmm.
thereby causing sort of severe pain during periods or around the periods time. The woman feels very uneasy, very much pain in the lower abdomen or lower back.
Mm-hmm.
So that is adenomyosis. Sometimes in combination with Asherman syndrome, I have seen.
Okay. Right. So, doctor, we have another query from Parul. She's saying that AMH was 1.98 at the time of first IVF. So, should I take hysteroscopy before embryo transfer? this
It is
time.
better. It is better. Now let us be very clear in this case. She should take the latest AMH. I mean the latest.
Hmm.
So if not done within the last 1 month, let her do
Hmm.
one now. And if it is still 0.98, if she has to decide whether she'll go for her egg pickup. In
Hmm.
that case, let her plan for an IVF first and then do a hysteroscopy so that she's not losing too much time on everything.
Right, right, right,
Yeah,
right.
hysteroscopy before embryo transfer is actually a good idea for, we do it for most of our patients.
So she would really like to take online consultation. So let's connect for after the session, and we'll definitely arrange this for you. So, viewers, if any of you have any particular kind of query related to your medical history, related to your reproductive journey, please let us know. Please post your queries. Ma'am, latest, like we can say that few of latest technologies. One is lit therapy. So, what you suggest, is it really useful when we are dealing with this recurrent miscarriage thing? People says
Uh,
that it's a kind of immune thing. So just
I was telling you now, no?
hmm,
Like there are certain patients who have recurrent miscarriages because of the immune response therapies or immune
right.
response in them. Anti-nuclear antibodies are positive, or sometimes their SLE factors are there. So usually we are taking help with our medical people also
Hmm.
to try and give steroid therapy also for them, so that we
Hmm.
will take come over, like even immunomodulator drugs also are used over there.
Okay, okay. When we were just discussing about this autoimmune thing, what exactly you suggest for such cases? Like, what could be the preparation period basically for these females before moving ahead with IVF or so?
Okay. In a repeated recurrent miscarriage persons, if we come across these ANA positives, SLE positives,
Right,
or
right.
DNA, all these immune related testing which we do and we get positives in them, we commonly are giving them steroids and immunomodulator drugs also. And when
Hmm.
it comes to early pregnancy, when the person goes in for pregnancy, we do ask them to say if her AMH is very good. It is not immediately that we are telling them to or recommending them to go for IVF. So we are actually
Hmm.
trying to support them with these medication, and uh, enoxaparin, that is low molecular weight heparins, will be suggested for them right from the time of first confirmation of the pregnancy. It could be
Hmm.
as early as just her dates are over, like she was due on say 10th March, 10th of May was her LMP, and say 10th
Hmm.
June she does not get her periods, and we do a beta HCG for that. We get a positive, we immediately start them with low molecular weight heparins, so that we are trying to support them during their pregnancy. And immunomodulator drugs and steroids are given well before also, well
Okay.
before also. And we would
Uh,
ask them to come for scans, early scans also, so that we see whether there is any other problem apart from, uh, of course, the confirmation of pregnancy by scan will be done. And
hmm.
frequent scans we do to make sure that we are not missing out on a missed abortion again, with the
Right.
support. And here in Chennai, I have a very good medical team one of our doctors, a senior consultant rheumatologist, Dr. S. Ramakrishnan, is actually doing lots of work into it. In fact, he collects so much of data for us, and most gynecologists here who are doing fertility practice and OG practice, no, we all
Hmm.
sort of look upon him to find out like if there is anything new, new avenues over here to try and treat them. But basically, these are the three drugs which we are trying to include in the further treatment.
Further treatment, right. So, viewers, if you are really having some issues, or we can say that some immuno concerns, then please, as Dr. Ma'am just mentioned, the name of the doctor and center, you can approach them. Ma'am, we have another query over here.
Yeah.
So I have a fibroid in my uterus. After then, I cannot conceive now for my second issue. My first baby is 13 years old.
Okay. How big is the fibroid? First baby is 13-year-old. Okay. So how big is the fibroid? Is it really causing any? What is her age? That is one thing.
Mhm.
Sanchita's age.
So I think you please provide us with the full details so that doctor will be able to answer this question. And obviously, fibroids depends on size, as doctor
Yeah.
just mentioned.
And where it is. I mean, if there is a 3 centimeters, 4 centimeters fibroid at the fundus, it really does not come
No,
in the way of pregnancy.
right,
So
right.
we have to find out where the fibroid is, how big it is, and her age, her AMH, because her first child is 13 years. So
Right,
there is a big gap in between.
right, right.
So
Uh,
certain more details are necessary.
yes, please. We still have few minutes for the session. If possible, please provide the details, and if not possible, then please connect. Sorry, viewers, on the screen our official number is flashing. So if sorry, any queries left, or you really want to know more about your situation, your concerns, and obviously in this live session it is not possible to address each and every query, please send us a message. We'll arrange an appointment or a call with doctor. Ma'am, we'll take another query over here. uh, I don't know about uh, Sigrun.
Surgeon syndrome. Okay.
Okay, Sirjon. My Sirjon syndrome and rheumatoid is positive. My age 32, but by God grace, I'm not having any symptoms of these. Is it necessary to start medicine?
Yeah. Because she already has known medical problems. These are the persons who would actually have a very high chance of miscarriage. So I'm sure whoever the doctor who's treating her for her rheumatoid arthritis would be telling her when is the right time for her to start the family. Um, this particular person has not told us how many years she's been trying for a pregnancy.
Right, right, right.
So we have to know how long she's been trying for a pregnancy, and as I told you, these people will be benefited very much with low steroid therapy and
Hmm.
immunomodulated drugs with no abnormal side effects on the fetus, and she would not face anything like a miscarriage during her pregnancy. So I recommend that she should always be consulting her gynecologist or the
Hmm.
obstetrician along with her physician who's treating her or the rheumatologist who's treating her for her rheumatoid arthritis and the Sjögren's syndrome.
So, ma'am, she is a mother of 11-month-old baby
Ah,
boy.
then okay, she already has a baby, so she
Right.
didn't have any problem. So let us like really not bother anything more about it. But
Hmm.
when she's planning for her next pregnancy, she has to keep this in mind. But she would
Okay.
not have any problem. I don't think. I mean,
Hmm.
unless and unless she has any miscarriage. But in my first
Right.
pregnancy, I lost my child cancer. So look, this is something what I was trying to tell. These are the
Mm-hmm.
person who stand a very high chance of losing pregnancies.
Okay. Right. Right.
She
Right.
had already lost one pregnancy, but I'm
Mm-hmm.
sure in the next pregnancy, her doctors have taken care of her medication for keeping in view about her medical problem.
Right. So on a regular basis, also she need to take medications, or this is
Yeah,
fine.
depends. No, not now. She
Mm-hmm.
might, if she's having any joint pains or knee pains or any commonly rheumatoid arthritis, you have pain in the fingers and these small joints. But if this particular person, she says that she never has any problem. So in that
Mm-hmm.
case, it is just that she will have a periodical checkup with her. Look, she's taking she was taking.
Aspirin.
Huh.
Yes.
Okay, and
I
she
think
had
during.
taken aspirin and heparin during her pregnancy. She would have
Right.
taken.
Right.
These are
Right.
the two drugs she was on. So
Hmm.
right now she might not require anything. Depending on her symptoms, her doctor would treat her. But we would not be treating her. Uh, and it's better to that she does not plan for a pregnancy immediately because she has a very small baby.
Right. So, doctor, just for I think my own knowledge, so when a person start with this heparin injection before pregnancy or during early pregnancy and all that, so do they really need to continue with this
Yeah,
heparin?
yeah. The
Okay.
person who had recurrent miscarriage and
Uh-huh.
had found to be having some immunological or anything related to their anti-nuclear antibody or I mean the APLA, that is antiphospholipid syndrome and all. These
Mm-hmm.
people need to continue their low molecular weight heparins. We usually give enoxaparin sodiums, say 40 units or 60 units, depending on the patient's need and patient's weight. But we would
Mm-hmm.
ask them to continue it up till the 37th week of pregnancy.
Okay. Okay. Understood. Right. Right.
It's a
So,
daily injection, but it is a
Mhm.
subcutaneous injection. But we would ask them to continue up till the 37th week when we actually plan for a delivery.
Delivery, right? Understood. Hmm. So I have pain only during winter, only in
Yeah,
ankle
yeah.
after sleep of 7 8 hours.
Yeah, so she is typically a rheumatoid arthritis person. So now probably she will just require some painkillers or some paracetamols. And
Mm-hmm.
I mean, I recommend for all these people to have a periodical checkup with their rheumatologist and
Mm-hmm.
definitely do something like daily physical exercises, healthy diet, like as in vegetables, fruits, and all those things, and
Mm-hmm.
something like pranayam, which is
Right.
actually a mantra for many diseases.
Right. So we can suggest that if you are really looking for holistic approach program, please let us know. We at Fertility Dost provide you with lot of holistic programs to deal with your concerns, and obviously we really wish you to stay healthy, and healthy pregnancy is the only way to healthy live
True,
birth.
true.
Uh,
Very much.
so, ma'am, like we discussed each and every aspect. So, one last thing, miscarriages, we always think कि female की वजह से हुआ होगा. That could be because of some uterine condition, some issues with egg quality. But what about the male part? Could
Yeah,
male
I
also
think,
contribute in
yeah,
this?
true, true. No, I did mention to you about it.
Right.
There are so many people where the woman was found to be like, at least when we are trying to evaluate a couple, when they
Mm-hmm.
come for their fertility issues, we are trying to do investigations on both. So
Hmm.
when we are investigating on both, we are actually looking at the male partner's analysis also. Like when we are
Hmm.
doing analysis or there, the semen analysis itself sometimes shows us the abnormalities. Something like very poor count and very poor motility, and the morphology of the sperms are very abnormal. Like normally now the WHO criteria itself says the normal morphology can be more than 4% is enough. So that means to
Hmm.
say the WHO itself accepts that around 95% of the sperms can be abnormal in some way or the other. It could be abnormality of the head, it could be abnormality of the mitochondrial, that is the mid portion, or it
Hmm.
could be abnormality of the tail.
Tail,
So
right.
when we are going to all these things, it will be like some abnormality over there. And I have seen in cases of multiple miscarriages or recurrent miscarriages, we have seen that when we try to do some tests like the karyotyping on the woman, on the partner, with the partners, that is the man and woman, we have seen many men having abnormal karyotyping. That is, so they actually have a chance of causing the miscarriage. So,
Miscarriages, right.
yeah, the
Understood.
karyotyping which was seen, that means to say that for those sperms the person has the genetic karyotyping which was abnormal, and that is the reason the embryos had abnormality. So in those cases, we have actually, what we have done is we have done PGTA, that is, we have done the embryo biopsy, and we see whether all the embryos are abnormal. So here is what we have benefited by doing a PGTA. We see that not all embryos were abnormal. There were, like
Okay.
when we sent about 10, say 10 embryos for PGTA, we saw
Hmm.
about 4 of them came as normal ones. 6 of them were abnormal. And out of those 6 abnormal ones, we saw that 1 or 2 of them showed the same abnormality the man's karyotyping had showed.
Okay. Understood. Right. So,
In
hmm.
say in one of the chromosomes, say chromosome 20. So there was
Right.
an abnormality of the same chromosome with those embryos also. So it is very important that we have to evaluate that way. If there is recurrent miscarriage and we rule out everything from the maternal side, like for example, as I told you, any abnormality of the uterine cavity. So you do a hysteroscopy, rule out that. Probably anything more than that, you can even do a hysteroscopy, laparoscopy, just rule out anything like a bicornuate uterus and all those abnormalities with the structure of the uterus. Oh, okay. And then
Hmm.
we try to evaluate everything else from the mother side, as in torch infections, any other infection, diabetes, hypothyroid, and which might have been the reasons of the previous miscarriages. So once we rule out all those things, we are like focusing now more at the embryo part. So when it
Right.
comes to the embryo part, and we have already done the investigations on the man also, we can
Hmm.
evaluate whether it is his reason or his abnormal sperms being the reason for the abnormal embryo over there. And doing a PGS in these embryos, that is PGTA.
Hmm.
PGTA is pre-implantation genetic testing for aneuploidy. So we are looking at the embryo, like whether it is a euploid embryo. So if it is euploid embryos, we use them for transferring. So it is
Right.
very important that we can do a PGTA and then transfer those embryos. You get a healthy pregnancy. Of course, there also we are tending to support them with some heparin injections for some time, some aspirin tablets for some time, because we really don't know, or we don't know at third month what could happen. So we tend to, at least for the first 4 or 5 months, we are trying to support the pregnancy also.
Right, right. And we really wish that diagnosis, proper diagnosis should be there so that,
Very
right,
important, because look, there is still, I mean, one thing which we should tell about ourselves is, like, there's still not much of a uniformity in all places, all centers. uh, uh, our country is a very diverse country, like you, it also is so in our field. So what you get in Chennai and the metros, probably you might not get in the tier 2 or tier 3
right,
places. So by the time a patient or a couple who wants to reach us out comes to a city and tries to find out, sometimes there is a time lapse over there. Her AMH might be very poor, or might, as you said, age is a criteria over there. They're coming at 40, 42, seeking pregnancy, but married for about last 14 years. So
hmm,
this I have seen happen very commonly when we did lots of camps near, I mean, in and around Chennai or in Tamil Nadu, when we were doing camps uh, to reach out to inform people that there are solutions. So at that time we noticed that many people don't even have an idea that semen analysis has to be done if
right,
there was no pregnancy within 1 year of married life. So, like, it's like 5 years, 6 years, there was no semen analysis. The woman had had a couple of scans, a couple of follicle scans. So that is the reason I'm telling there is no uniformity, because 1 year of married life, a couple is not conceiving, having tried for those 1 year. We know it is primary infertility. There are tests which can be just evaluated within a month or two, and you can come with a diagnosis what has to be done, diagnosis and the solutions.
solutions,
So
right.
so
They
it
are
is,
really important.
yeah, very
And I
important.
think viewers, by this, like towards the end of this session, you must have gained a good amount of information that how and when you now move ahead with your process. So please don't delay. Find a right doctor at right time in your city, at your place, which is really important. And again, if any of you really want to connect with Dr. Dakshani, please let us know. Our official number is on the main screen. Just send us a SMS, WhatsApp, or just a simple call, and we'll arrange for everything. And Dr. Dakshani, thank you so much for joining today. I know you have a very busy schedule, but aapne time nikala. We are really grateful to you. And thank you, UNS. Thank you once again for arranging the session. Thank you, ma'am. Thank
Thank
you.
you.